Good morning. So Michael Akinyele, I help lead our innovation efforts at the corporate level at the Department of Veterans Affairs. I've heard a lot of talk about millennials earlier today, so I'd like to announce that I am a millennial, and therefore the focus of our innovation efforts are actually preparing the agency for VA 2045, when our population of veterans are actually going to go from 20 million today down to 12 million, and we need to figure out how our sort of national strategy and the infrastructure we have in place can actually meet the needs of that population size at that time. Supporting this effort is the recently enacted VA Mission Act. Section 152 of the Mission Act authorized the creation of a Center for Innovation for Care and Payment. So that center is unique for a couple of reasons. One, it comes with waiver authority to request sort of waivers to things on statute that allows us to deliver care slightly differently, pay for care slightly differently, and so with that, we're sort of pursuing the triple aim plus, the additional pluses around improving access and improving timeliness of payments. The other piece I'd like to call out with that is it also comes with funding authorization for $50 million on an annual basis, as well as the opportunity to develop and pilot about 10 pilots at any given time. So the conversation around alternative payment models came up as a result of this new law and the creation of the center. And I'm delighted to be joined today by David Muhlestein and Bill Borden. And what I'll also add, almost as an apology at the front end, is as an MBA and with a physician and a PhD and a JD talking about alternative payment models, we're going to try and stay outside of the wonky side of alternative payment model talk, but it has the propensity to get wonky. So I just want to apologize in advance for that. So with that, I'll allow both David and Bill to introduce themselves, talk about their organizations, then we'll get into some questions.
So David Muhlestein, and alternative payment models is something I spent a lot of time with. And the theory of alternative payment models, for those of you that are not familiar with them, is the idea that if you can pay differently for care, then people are going to have incentives to provide health care in a different way that's going to lead to better outcomes, the triple aim, better quality, lower costs, better patient satisfaction. And that's the theory of it. And when we focus on the payment model side, that's the first piece of the puzzle. How do we pay for care differently? And that's something that people have been grappling with. CMS has done a lot of this, commercial payers have done a lot of this, Medicaid organizations, some Medicaid agencies have done a lot with this. And it's that challenge of trying to figure out how do you pay for care differently? Well, there's also that middle piece, which is how do you deliver care in a better way? And it's not like there's some magic light switch out there that people are just waiting to turn on. As soon as you pay differently, we're just going to take much better care for our population. There's a lot of learning and challenges that go into that. And there are a lot of requirements. You need better technology. You need better coordination. You need to have alignment between a variety of different providers, from primary care to mental health to pharmacy and everybody in between. And how do you change not just how you think about healthcare, but how do you deliver it, and what is the opportunity for that? And so there's been a lot of activity trying to make this transition, but we haven't got the payment models right, we haven't got the delivery models right, and we have not yet achieved the changes that we want to have yet. And so there's a lot of opportunity to innovate and to try to come up with new approaches to managing this. One of the biggest challenges that people grapple with is the business side of it. Because when we look at it from just a purely altruistic perspective, we say, yes, we want to provide better care for our patients. The problem is if the business model does not align with what we're actually doing, we can't keep the lights on, and that ruins our mission. And so how do you create a business model that enables people to make this transformation? As Michael mentioned, we're living in a fee-for-service world, and that gets into the wonky area of what does it really mean when you're in this fee-for-service world? What the reality is there's not necessarily the incentive to coordinate care and to manage care. And so how can you move away from this? Well, first of all, we're stuck with fee-for-service in a lot of parts of the healthcare system. So what can we build on top of it? And there's lots of challenges when you're building on the foundation that none of us would really design if we could start over from scratch. But then if you are in that world and you start to build on top of it, how do you help organizations make the transformation when they're still dependent upon the fee-for-service for the vast majority of their revenue? And that's where we're at right now, where there's a lot of people that are experimenting, where they're saying, let's take a little bit of money under these alternative payment models and see what we can do with pilot programs and try to innovate and really try to change things. The challenge, though, if you're an organization that gets 90% of your money through fee-for-service, then fee-for-service is going to dictate your strategic choices. And until you can get a sufficient amount of revenue at risk to justify changing your delivery systems, you're not going to see the outcomes that you want. But until you're good at providing care, you can't justify moving toward these alternative payment models. And that's where we're at. There is the need to be better before we take on additional risk. But until we take on additional risk, we can't justify doing what's necessary to be better. And that's where we're at right now as a country, starting to experiment, starting to figure out where there might be opportunities. But we still have not gotten over that hump of saying, we know we can do this now. We're willing to move toward this risk. We're willing to take on these new alternative payment models. But that's where we're in. It's in this fascinating period of time when we get to experiment, we get to learn, and hopefully leave our mark on healthcare going forward.
Great. Well, good morning, everyone. Bill Borden. I'm a cardiologist, and I run our ACO and our quality efforts at George Washington University's Medical Faculty Associates. And thank you, Michael, for having us here today. So I'm going to start and tell you about a patient that we saw a couple of years ago. So this was a 67-year-old woman. She had heart disease, she had chronic kidney disease, she had emphysema. But she also had low health literacy, she had financial challenges, and she had been in the hospital 3 times and in the emergency department 5 times in the previous year. You know, obviously this woman is complex, but this is exactly the type of person that we as healthcare providers and we as a healthcare system need to take care of. And if we can provide better preventive care, better chronic disease management, you know, this woman is healthier. She's at home, she's happier, and importantly, she's not in the ER, she's not in the hospital. And so then that, from a system standpoint, saves us money. This is, to me, that's the essence of value and what we're trying to get. And I've definitely drank the Kool-Aid. I'm in. You know, we need to get towards value for exactly patients like the woman I just described, which is if we can get better health outcomes, and that needs to be first, I think that we also can, at the same time, lower costs to the system, which I do think we have an obligation to do. So these movements towards alternative payment models, and David, I think, really nicely summarized the current state of affairs, I think is really promising because it creates the business model to provide that care across settings and across time. So at GW, we've been in Medicare Shared Savings Program Accountable Care Organization, ACO, which essentially creates an incentive to provide higher quality care and to control the overall costs for a patient. We were in our first ACO. We were able to achieve high quality scores throughout and get shared savings, which we were very proud of. We're now into our second ACO. And I think we've been doing a lot around this care coordination and really using this as that stepping stone to transform ourselves into an organization that provides this sort of population health management. Since it is Health Innovation Day, I thought I would talk about one innovation that we have implemented that is helping us along this pathway, which is actually to take advantage of a public-private partnership in the DC region, something called CRISP, which is our Regional Health Information Exchange. Now, health information exchanges around the country, I think, are variable in terms of how well they work. I think we're very fortunate to have a pretty mature HIE that's been beneficial. And it provides really 2 main functions for us. One is we can log in and see, say, an X-ray or lab test for a patient of ours who is in a hospital across town or somewhere else in Maryland. And that's really helpful so that we're not repeating tests. We understand what our patients had done elsewhere. And now we've actually put a single sign-on in our electronic health record that our providers just click one button, brings you right into CRISP with the patient in context to bring that information to your fingertips when you need it. The second piece that it offers is that we get admission discharge transfer, or ADT, notifications on a daily basis. So we can know when our patient lands in an emergency department across town or gets hospitalized so that we can coordinate care. And what we've done is we've taken that data feed and plugged it into an app that our providers and our nurses can have on their phones so that they can be notified in real time when a patient's admitted. So I think this is the sort of technology and innovation that directly relates to the care processes and trying to provide better care for our patients. So just sort of close my initial comments by going back to our initial patient that I described. So using some of the programs we put in place through our ACO and working with a care navigator, we connected this patient with primary care, coordinated amongst our specialists, connected her to transportation, food services, and through that she went from 5 emergency room and visits and 3 hospitalizations to the next year, just 1 emergency room visit, no hospitalizations, to the next year, no hospitalizations, no ER visits. That's the type of care that we want to deliver, and that's where I think these alternative payment models are trying to change the business case to deliver that sort of care.
Thank you, Bill, and thank you, David, for that sort of introduction. So what we're going into now is a couple questions, and I'll see if there's a possibility of having some audience questions as well. So I'll ask that the responses be as brief as possible so we can get through as many questions as possible. So what overall grade would you give the current state of the U.S. alternative payment model ecosystem, and what external forces are likely to disrupt the fee-for-service architecture that ultimately serves as the foundation for payment models today?
Yeah, I would give it a C right now. There's a C because there is a lot to be done. We have not figured it out yet, but we have started the conversation around it. And as I mentioned, we're in a learning phase. And you know, when you're kind of at a learning phase, you don't know exactly how you're going to be once you've learned what you can. But people are talking about it. There are a lot of people that really believe that value and focusing on value and new payment models is necessary for the future, and I'm definitely a believer in that. But there's a lot that still needs to be done. And there's that question of, can we build all of this on the fee-for-service chassis? And I won't get into the details of all the challenges with that, but it is a major barrier. I think one of the things that we can look forward to is when people move away from fee-for-service and where that can start to play out in alternative payment models. This could be in capitated contracts, it could be in other approaches, but really saying, what if we stop focusing on every little piece of the puzzle that was used and instead just focus on how we can collectively care for the patients in the best way possible? If we don't have to assign a CPT code for everything that we do, we're going to have better outcomes. When we're limited to what we get billed for, that really reduces our effectiveness.
Yeah, I think, so I agree with David. I might give it a little higher grade. I'll give it a C+. You know, we're doing okay. We're about average, and we can get up to a B or an A, but I think there's also a risk that we could fall back to a D or an F. And so it's a delicate time. There's been a lot of great things that have laid the foundation. I think those building blocks are in place. I think that providers have sort of come to an acceptance around this is the way that the world is going, and that's a huge cultural change that needed to happen. I think that the pieces that we need to do going forward to make sure this transition continues, one is we need to get the speed of this transition right. You may have heard this analogy that we're in this phase where we're 1 foot in 2 canoes, one being fee-for-service and one being alternative payment models. That's a precarious position to be in. I think we need to accelerate it, but I think we can't go too fast because then people may regress towards fee-for-service. That's one. 2 is we need to get much better on our quality measures. We're a lot better than we used to be, but we need to have a better understanding of them. They need to be less onerous to gather those data, and they need to relate to the outcomes that our patients really care about. And so I think that the third piece is around those sort of what are the tactics, sort of what I described around our use of CRISP, our use of nurse navigators. I think we need to have a better understanding for health systems that want to do this. Okay, what are the X's and O's? What are the things that you do to be successful? And I don't think that we have as a community a good understanding of what that is yet.
Thank you for those great responses. I'll like to add a follow-on and then see if we can get a question or two from the audience. So the follow-on is between disruptive technologies like blockchain that could potentially replace the payment architecture and the regulations that currently drive our payment ecosystem. From your perspective, what which of those two, or potentially a third, could be most disruptive in this potential shift away from fee-for-service?
So I think that any change is going to have a regulatory component.
Yes.
And that's something that healthcare is one of the, if not the most regulated industries in the country. And so whatever we do, we're going to have to be open to new ideas. The challenge with any new technology, particularly if it's coming from a government or policy perspective, is that people that have vested interests are reluctant to take that on. Yeah. I think if you can see positive proof of concept that's coming from potentially outside of the government sphere, and then saying, oh, this is better, we will now go and adopt it, I think there's more opportunity than trying to adopt it more from a top-down approach.
Okay.
Yeah, I would like to say the technology, but I think being realistic, I think it's the payment model. My advice to the innovators out there is, think about the end user of that innovation, of that technology, whether the patient, the provider, and particularly if it's going to be going towards a health system or something else, think about how it's going to fit into their business model. And as the business model changes, I think that'll open up space for some of these technologies to really take hold.
Excellent, thank you. So want to give an opening to the audience if there's a question or two. Okay, we have a couple. Just make this a little bit interactive.
Hello, Bill Cohn with Salesforce. It may have been the timing of the presentations. Have you looked at using alternative payment model to maybe encourage more donations? I understand you can't pay for a kidney, but maybe take the disincentive out of somebody donating a kidney with how to cover their lost wages, their own medical expenses, and things of that nature, to try and get some different results by changing the system that way.
I'm not aware of any that have happened yet. Certainly an interesting idea. There are a lot of things that need to be changed similarly. So for example, Stark laws are something that can be basically done away with under an alternative payment model. I think you could look at organ donation as a potential thing that could be looked at too.
One add-on comment is, I like where you're going with this, which is we need to stop thinking about one individual slice of the whole patient or the whole context. And sometimes it's paying for things peripherally to what is, say, the actual surgery. CMMI put out this accountable healthcare communities model, which is looking at linking to community services, recognizing that a patient's medical conditions are one part of their broader life. It's their access to food, it's access to transportation, other social services, and the current administration's made some moves towards looking at ways to pay for those sort of ancillary social services that help support one's health.
Thank you. I see the signal, so we have 2 more minutes, so I think this is probably the last question.
Real quick, Tom Castles from Leidos. People who talk about ACOs often talk about patient at the center. Very rarely do you see alternative payment models that are paying those patients for specific behaviors. Do you see that becoming a bigger part of future models?
I think so. I think getting the patient involved in any way that you can and recognize what people respond to, and people respond to incentives. That's the first law of economics. The second law of economics is we have no idea how they will respond to incentives. And that's the challenge to grapple with is what are you paying them to do, or how are you involving them in a meaningful way? So under the Medicare programs, there's now where people can get, it's like $50 for getting annual wellness visits. So very modest payment, but there is some sort of incentive to do something. And so I think Medicare is open to that idea. On the commercial side, people have considered it as well. But how do you incent people to get involved? And their pocketbook certainly is a strong incentive.
Yeah, I think we definitely need to do a better job of engaging patients in these healthcare systems, whether it be through financial incentives. I'm not totally sure about that, how I feel about that. I think time will tell. But someone who runs an ACO, we need to do a better job of letting patients know that they're part of this, what opportunities are available, and how to help them get engaged in their care.
All right, with that, I'd like to thank the panelists and the audience for this time. Look forward to engaging others throughout the rest of the program. Thank you.